health HIV integration agenda. As populations across Africa grow, there's increasing attention to what are the best approaches to provide care to clients in a way that meets their needs. Client-centered care. And this has brought a lot of discussion, especially in the realm of reproductive health and HIV. As was alluded to earlier, we know that one of the ways that has been considered is integration. And that has implications for planning, there are implications for financing, and even the execution of integration. Changes are introduced into the health system, and often they require policy support. The question that is asked in many countries is then who provides the leadership for that in the long term? We know that integration has the potential to improve outcomes. As Michael alluded to, this has been articulated and endorsed in many international fora, and it is seen as a way to accelerate or to scale up the achievement of the MDGs. This here is an illustration of integrated services taking place in a provincial hospital in Western Kenya. The hospital has integrated HIV services into an MCH setting, and here mothers are able to receive family planning services, their children get immunization and all that pertains to child health. The mother gets ART and everything else with living positively, and even malaria interventions, because this is a region of the country where malaria is endemic. It's really refreshing to visit this hospital. The health workers are very motivated, and the mothers are very relieved that they don't have to have waiting time in long queues at the comprehensive care center. So since we know this, we are going to ask the question, has there been progress in integration? Over the last decade, many countries around sub-Saharan Africa have piloted and looked at integration. But scale-up seems to be slow. And the question is, who is the leader or the champion beyond that clinical trial, beyond the pilot, to see that it's replicated in other settings? There's a growing body of evidence, and this conference will provide the opportunity to hear from many of you about the good work that you're doing. However, there is still some ways to go. In many instances, there's a need to look at policy, and there needs to be consideration of what strategies are best suited to that country, and definitely health systems need greater attention. Innovative approaches for financing will be required to scale up integration, because the reality is that there will be costs to integration. So, if the situation is that we have a lot of countries that are conducting some form of integration, we know the different models that have been presented, we have pilots going on, clinical trials, some attempt at scale-up. What do we need to do so that we can actually get this train moving? In this conference, as I said, we're going to hear a lot of models. But for the long term, how can we make this a coherent process? What's a good place to start? One good place to start is with costed national plans that support integration. And in many countries, they are there because governments look at a holistic program. There is need to look at policies that will facilitate integration. For instance, that will enable task shifting so that at the lower levels you can provide a comprehensive package of care that we're talking about. There are policy changes, for instance, to allow family planning services into HIV settings. In Kenya, almost a decade ago, this process started with the entry of PMTCT into ANC settings and also then family planning into HIV settings. Integration will also need us to look right from the community level and along the health service pathway, determine what needs to be done. For coherence, it's good to have a strategy, because a strategy gives you ideas of who should be involved in decision making. How do you coordinate? How do you plan this process? It helps us to look at health system needs, because there are, as we expect, there will be changes. To look at finances, where will these resources come from? The monitoring and evaluation, so that we can see, is it actually improving the client-centered care that we're talking about? The reality is that there may not be adequate services to do comprehensive integration, and we're not saying here that integration is a panacea. But given that often resources are limited, perhaps it's good to come up with a minimum package of service that describes different models of integration in inpatient and outpatient settings, and even in the community, and the basic needs. What equipment do you need? What commodities do you need? The human resource skills you need? The job aids you need? What kind of resources will you need? Supply chains, referral systems. The minimum package or the strategy are only as good as the user who has access to them. So if they end up just being documents that sit in a shelf somewhere in some health manager's office, then that's not helpful. So they need to be used. But then how do you systemize this integration? How do you ensure that it happens, as I keep saying, beyond that pilot? This is where leadership is required. And in many countries, you can't really know the leader or the leaders of integration. This process of leadership is important so that we can sustain the good work that we are seeing developing, and also that we can look at scale up. Organizational change. Integration brings with it the inherent need for change. Reorganization. And it's not just limited to community, it will be in a facility, it will be between facility, it will be at the national, the regional level. If we're to look at coordination and planning, we need to have stronger linkages between vertical programs if we are to support integration. And this needs to happen at all the levels. If we are to sustain integration, then we need to look at referral systems. From the community to the facility, within the facility, between facilities, depending on the model of integration that we're offering. What about supply chain and the availability of a variety of health commodities? This needs to be looked at comprehensively. Human resources. Are they trained? Are they supervised? Are they motivated? The question of commodities. If you have an efficient ARV supply, and you have shortages in vaccines, for instance, or contraceptives, or even the necessary reagents for cervical cancer screening, then this will dilute your integration model. Human resources, we need to be careful about the deployment of health workers in the integrated model. It won't serve our purposes if, for instance, you have a health worker who is doing counseling and testing and sees 8 clients a day, and then the one in the integrated settings is seeing 80 clients a day. Burnout and demotivation will set in. Space is a real issue. Infrastructure. Putting these services in one room or rooms that are related requires thinking, and that requires resources. And then, of course, we talked about monitoring and integration. All of these are pointing to the importance of health system strengthening. We need to approach integration not just from looking at that facility and what's going on there, but how is it affecting the whole system? And this brings me to something that I want to talk to you about. I want to ask the question, is integration that easy? Certainly not. There are potential hurdles. I want to address what I'm calling the D phenomena that can be a potential hurdle. Many countries have institutionalized vertical planning. And if you look at the way the ministries of health are set up, you have divisions or departments that deal with, for instance, family planning, maternal, newborn and child health, HIV/AIDS, malaria, TB. Vertical planning. Often there are technical working groups or task forces or committees, integrated committees, that are overseeing the works of these different divisions or departments. Can these committees, as they begin planning, work together so that integration is supported right through the system? From these divisions often comes vertical supervision. If a program manager is going to lead the national program and come to the district and the facility to do vertical supervision of one disease or set of services, that's not going to help integration. So there needs to be real thinking right from the outset of planning about integration. It's not just what happens at that facility. That's the first D. The second D are donors, development partners. External resources can and will help in integration, but we know that in many of our countries, what donor funds have done is that they've introduced or entrenched vertical programs. They provide funds for a specific disease or certain services. And that goes then against integration because they have very strict, sometimes, rules about how you spend the money. So when you come down to the facility where integration is going to occur in the community, you may have an imbalanced setting where you have a group of health workers who are highly motivated by this vertical program because they're getting training, they have job aids, they get per diem, they get nice trips, and then the other programs lag behind because the government resources to back them don't bring those goodies. So again, that needs some consideration. The good news is that there is global recognition that something needs to give, especially with external resources. And increasingly, funds are being targeted to health systems. So for instance, if there are funds available for supply chain, they shouldn't look only at one commodity. They should actually help to strengthen the whole system. And likewise, for the HMIS, if we're to be true to the spirit of integration. The provision of healthcare is the mandate of governments. And often these resources come from the government itself, from people, from communities, from private sector, and external resources. When we're discussing integration, then we'll need to think how to better align these resources. And that's why I refer to flexibility in the use of external resources. Some countries have started results-based financing, which does have the potential actually of supporting integration. Because, for instance, if you apply performance targets to every service area in the district or in the health facility, it will encourage the facility to think innovatively. And sometimes that innovation will bring integration. Private sector continues to be a very critical provider of healthcare in our continent. And as we are discussing integration, we need to remember that we need to look at the many small clinics where many of our men, women, and children will go to access care and see what technical assistance could be extended there so that these good things or the good outcomes that we anticipate in integration also extend there. We also need to regularly review progress. We need to find out, are clients getting satisfied? Are the systems being strengthened? What is the health worker experience? And ultimately, what is the impact on health outcomes? So in conclusion, as we look at policy and organizational change, remember that we're not discussing integration for integration's sake. We're focused on client-centered care. And it's about the system and how we need to strengthen those, how we need to better plan so that what started off as a pilot, as a clinical trial, supported by some NGO somewhere, can be replicated and scaled up in other settings within the country. Health sector plans prepare for an integrated provision of services to different cohorts of the population. That's what we need to support, and not the vertical planning. But we need leaders. We really do. We have leaders at the implementation level for integration, but often we don't have writ large for the big picture. For long-term change, we will need that. And then recognizing that all of this requires great movement, right from the communities, into the facilities, into the districts or counties or federal, state, and right up to the national level, then we know that this is going to be a partnership. because we can't do things alone. So the long term is that as we change, there are many, many factors that we need to consider. But given that this is a partnership, I think that we can make progress. And perhaps this conference will be the start of a lot of things that we can discuss a decade from now.